As the global population ages, life expectancy has risen to 70 years or more in many countries. According to the World Economic Forum, 2020 marked the first time in history that individuals aged 60 or older outnumbered children under 5. FSC's 2024 Insights and Trends report highlights that life expectancy in New Zealand has increased by 11 years from 71 in 1960 to 82 in 2021, with women living approximately 3.5 years longer than men. However, this increase in lifespan has not necessarily translated to healthier lives, as many of us spend the last decade of our lives burdened with disease or poor quality of life. Now, on our panel, we'll get the panelists to introduce themselves. They will be tackling this today and seeing how technology can actually help us bridge the gap between health span and lifespan. Starting with Kate.
Kia ora everyone, ko Kate Reid tōku ingoa. I'm a partner in our health practice at Deloitte. I lead our digital health work, and anything that really touches health and technology is my game. I'm also the chair of the Digital Health Association for New Zealand, which is the industry body that represents digital health organisations across New Zealand. About 210 members of that organisation currently doing a ton of work in this space. So really thrilled to be here. Thanks.
Thanks, Kate. Good afternoon, everyone, and thanks to those of you that have made it into this room. I think there's a lot of fantastic topics on in the various other breakout sessions at the same time, so thanks for joining us. So as Arishma mentioned, my name is Alex Kühnast. I am the Chief Product and Strategy Officer at AIA New Zealand. Fairly new into the role, 4 months in. Previously held a range of other roles in both the consulting industry as well as various insurers around the world, in both all of New Zealand, in Europe, as well as South Africa. And I think, as Arishma mentioned, aging populations tend to be a front of mind topic for a lot of first world countries in particular. So AIA being the largest life insurer in the world and active in 18 markets around the Asian Pacific region, we have a range of different profiles. And certainly speaking to some of my colleagues, particularly in South Korea, for example, there's a massive problem. So as you've got your population aging to the extent that theirs is, you've got natural knock-on impacts, both in terms of who will look after these elderly people and then economic impacts as to who's going to be doing the work in the workforce. So hopefully we can have a good conversation around that, as well as what we as insurers can be doing. I think another key point is certainly front of mind for a lot of us, certainly the health insurers in the market, not just in New Zealand, but globally, is health claim inflation. So that's really skyrocketed around the world. It's always been a bit of an issue, I think, outstripping wage inflation in many countries for a long time. But we've seen a bit of an increase recently, and it's having done some analysis across our book, it's certainly not specific to any unique causes. So we've got an increase in incidence as well as the average claim cost across the book. And then as well, a range of onshore as well as offshore impacts, some really intriguing ones, speaking to some of the hospital CEOs, things like consumables, medical gases, which are produced largely out of Germany, which have seen an increase of 40% off of the Ukraine-Russia conflict, which is supplying energy into Germany to produce those gases. So rather some strange knock-on impacts. But that's quite a long intro. I'll hand over to Cecilia.
Kia ora, Cecilia Robinson, ko Cecilia Robinson tōku ingoa. We have what is now New Zealand's largest primary healthcare, one of New Zealand's largest primary healthcare organisations. We're the largest, I'd say, digiphysical, fully integrated primary healthcare organisation. Previously, my husband and I have done a couple of different businesses. We did early childhood, and I swore off ever going into an industry that did government funding again, and somehow ended up in primary care. We did my food bag, and had the privilege of having a really interesting experience there, exiting and looking at lots of charitable initiatives. And thinking about where we could best spend our money to really generate return for New Zealand and how we can make a difference, and kind of played with some charitable things and then realised that we needed to kind of deploy our capital and our skill set at the same time. And so that's how we found ourselves dedicating the rest of our lives to helping make New Zealanders the healthiest people in the world. And we're making some really good progress here, and just noting that the state of primary care is all over our news every day of the week. And it's a complex problem, which is really the foundation of our whole healthcare system. If primary care breaks, everything else breaks. We have to be really clear on that. And so, so I'm intrigued about the conversation today and looking forward to some of the questions coming through.
I guess you've all sort of alluded to that there is this looming social healthcare crisis, and some of the technological advancements we have in this space is going to make an impact going forward. Now, Cecilia, because you've touched on it, with telehealth, virtual consultations, and teletherapy, this is revolutionizing our healthcare system and making it more accessible and efficient, but we do see a gap in our older population being included as part of that digital inclusion. How do you see that becoming more inclusive and delivering for the older generations in our population?
Well, I think a little bit it defines how you define old. So I think there's a little bit of a fallacy there. You know, I attended Integrated Pakuranga Medical Centre 12 months ago, and our fastest growing cohort onboarding onto the technology was 65 plus. So I think perpetuating the narrative that older people don't choose technology is incredibly unhelpful. It's actually not true. In fact, all of us are probably actively trying to keep our parents off Facebook. I know I certainly am. So, you know, that's a work stream in itself. And so actually what we're finding is basically the opposite. Is we're finding that the older population are really good at onboarding with technology. In fact, the people that are 65 were 10 years ago were 55. They're actually quite savvy, and because they have day-to-day needs that they need to manage because their healthcare is complex, they actually are quite able to use it. And in particular, if you've got really well-designed technology, and what consumers are saying is that they don't want shit healthcare technology. They actually want usable healthcare technology. And that's what we're building at Tend. So I broadly disagree because it's not aligned with what we're seeing at Tend. We're actually seeing really good onboarding in our 65 plus, but acknowledge the fact that that's not across the whole population, and we need to continue to do work there.
Yeah, absolutely. Now, obviously, there's a lot more cutting technologies available now, like health apps, wearables, smartwatches, health data analytics that actually continue to provide information around management for chronic conditions. Where do you see that actually taking healthcare in the next 5 to 10 years?
So, I mean, I can answer some of that. I think in some ways, technology is a huge enabler for elderly aging well in place. So if you think about what's exciting for me about this reset or reform reset that we're living through at the moment with Health New Zealand and the health system, is the operating model is set to switch. And I think this is exciting for disruptive organisations like Tend, to, instead of the default position being caring for somebody in a hospital, which is pretty much what we've got at the moment, which is a sickness system. We treat sick people. We don't prevent sickness from happening or ensure people stay as well as possible in their home. So a complete flip is needed on in our operating system for healthcare that enables people to live well as long as they can, as well as they can, in the place that they want to age. And if you think about that, for most people, that's in their home, in their communities, where they feel safe, where they have social support systems. And we often say, you know, the most unsafe place for somebody is actually in hospital. Acquired deterioration is a real thing, particularly for aging people who tend to get a bit forgotten. And so I think technology, if you think about how much time people spend in the home and very little time in front of a care provider, actually is a huge enabler for switching that operating model. The challenge we've got, I think, is scale and pace And it was really interesting sitting in the digital identity session before, because they talked about a fully interoperable health system or system and digital identity. We don't have those in banking, but we also don't have them in health. And those things would really definitely help us with things like wearables and where that data goes, how organisations like Tend and other care providers can take that data and do something with it. So we are very data rich in health, but we're very insight poor, and that's largely because we have siloed systems tethered to care providers and not shared in the places they need to be shared.
So how do you see that, Kate, like in the future, balancing that with human interaction to be delivering compassionate and inclusive care?
Well, I think it goes back to, when you talk to a patient, the single biggest frustration they have in the healthcare system is that every single person they talk to asks them to repeat their story. And largely that's because the data is tethered to the care provider. And if you think about an end-to-end model of care, we don't have an end-to-end interoperable system where the data follows the patient between care providers. It's very hard to provide compassionate care when you don't know the person sitting in front of you. Data, technology, innovation helps us with that. It helps us be more relevant. It also helps us personalise the interaction with that person down to an N of one. So that person sitting in front of me or virtually or through my digital app has their own health experiences, brings their own experience to health. And so I think we can be much more compassionate and caring, and I'm sure you both have comments on that.
Yeah, I mean, I think part of our objective as an insurer is actually to keep people out of the healthcare system. So I think between government and the insurance industry, we're probably two of the only entities that spring to mind that benefit directly and financially from people being healthier and better off. So certainly I wouldn't be an actuary, and not an actuary coming from South Africa, if I didn't have some sort of reference to vitality. Luckily now I'm working within the AIA remit, and that's certainly something that we focus on quite strongly. So we've just celebrated our 5-year anniversary of launching AIA Vitality within the New Zealand context, but globally I think Vitality now covers over 40 million people, and through 41 markets through Discovery's various partnerships around the globe. And some of the stats that we see there are really interesting, and how we can, through really preventative healthcare and identifying issues early on and treating them early on, we can keep people out of the healthcare industry, out of claiming. So, I mean, if I refer to our New Zealand 5590 plus research, where we identified 5 modifiable behavioral risk factors that really drive 5 of the key non-communicable diseases that lead to over 90% of deaths within the New Zealand remit, those being smoking, physical inactivity, unhealthy diet, excessive alcohol consumption, and our interaction with the environment, which all influence those non-communicable diseases such as cancer, diabetes, respiratory and cardiovascular disease, as well as poor mental health. So the premise behind Vitality is really just to through the use of not just wearables but also scans and pre-screening, to really raise the awareness of health conditions within society, and then beyond that actually incentivizing and prompting individuals to improve their health. And if we look at just the stats that we've achieved within New Zealand itself, it's quite remarkable. I think we've had over 18,500 Vitality health checks performed by members, and that obviously gives them insight into where their unhealthy markers are. And then of those that have performed a follow-on health check, so they would have perhaps identified certain health factors, key health factors that are perhaps in unhealthy ranges, things like glucose, cholesterol, high blood pressure, etc. We've seen a 79% improvement from an unhealthy state on glucose to a healthy state at the next testing, a 64% improvement on cholesterol level, moving from unhealthy cholesterol levels to healthy, and a 49% improvement in health state on blood pressure. And I think those are some pretty startling figures. I mean, if you're able to really incentivize the population to better understand and then control their health, I think that's something that we inevitably have to move towards if we're going to better manage these health conditions within society.
We've got some questions from the audience. How do you bridge the gap of prevention costs overlapping with ongoing costs before any benefits of prevention are being realized in such a high-cost environment?
Sorry, could you just repeat that?
Sure. How do you bridge the gap of prevention costs overlapping ongoing costs before any benefits of prevention are being realized in such a high-cost environment?
Yeah, sure. So, I mean, these sort of screenings are fairly low cost and currently funded through the benefits that you see already. So you get additional through the benefit program and the rewards that we pay back to members. We've paid over 9.1 million New Zealand dollars back to members in rewards. That drives additional persistency, etc. And there's a tangible benefit both through the reduction in claims and improved persistency that comes through the book, which immediately treats through on the assumptions that underpin the financials, which frees up some financial allowance to fund some of these benefits. At the moment, sure, whilst we build up that experience, some of that we are funding ourselves. But certainly in mature schemes like you see in Discovery in South Africa, a lot of it, that value is just there to be shared back with policyholders, and that's the premise behind the shared value insurance model.
Cecilia, there's one for you as well. It says there's much talk of telehealth, but what's the split of digital versus physical consultations? And are the same people using both all the time, or is there a specific need for specific populations?
Yeah, so we try to not talk about telehealth when we talk about digi-physical care. And so by that I mean that we've got a digital health solution and we've got a in-person health solution, which is why we've bought practices, we're a fully integrated model, and by that I mean we're going through the pain of acquiring legacy infrastructure and rolling out new operational models across that legacy infrastructure. It is complicated, it is hard work, right? In our green sites, where we are fully tend from day one, where our patients choose us, where our clinicians choose us, the patients on board and they see us in whatever way is most convenient to them. In those environments, up to 50% currently is being seen online. And only about 5% of those that are seen online then get triaged into clinic. And often when they get triaged into clinic, it's because we need to look in their throat or we need to look in their ear or whatever else has happened. Within our broader network of acquired practices, keeping in mind that our data is fairly new, we did our first integration a year ago, just over a year ago. We're doing another 3 in September, so we've done 11 over the course of the last year. 32% of our acquired practices we're now seeing online. But actually, more importantly, what we're doing is we're able to distribute the need for healthcare in regions to central support teams. So it means, for example, in the Bay of Plenty, we're able to move out 400 appointments a month out of our practices in person, and we can serve that need through our central channels, which can be delivered from anywhere across the country. And so, but the whole model has to work together. You can't just take physical care without, and not have digital care, and vice versa. You can't have digital care without physical care. Just defeats the purpose, and it doesn't lead to better healthcare outcomes if you do, right? But more importantly, I think what people don't understand when you're talking about things like wearable technology, our systems are so fragmented. Coming into healthcare out of technology has been horrifying. It is horrifying. It is the worst technology I've ever seen in my life. You're literally talking about a server in someone's small practice that's got 3,000 patients, and if it sets on fire tomorrow, then your medical record is effectively gone. Like, it is, Windows, 97, like, it is bad. Like, this is so bad. So before we're able to integrate things like wearables and all these other wonderful things into our technology, we actually just need to do the baseline. And the baseline is to have one digital health record across the clinics. And the benefit tend is that you have the app, you go onto the app and you go, I want a medical appointment, and it can go, okay, well, I need someone who sees someone urgently. You can join our queue, or you can see us at one of our practices. It means that you can move between practices. You don't have to be wedded to the one that's 10 minutes down the road from you. You can go to Pakuranga because they've got an available appointment, or you want to see a paediatric specialist, you can go to Simon Street, or you can go to radiology at Simon Street. Or if you're in the Bay of Plenty and you get sick, you can go to a Tauranga practice there, and the same in Christchurch. So, like, the system is so much more broken than what people believe, and the aspirational future of where we need to get to is further than what people understand because of the physical infrastructure and the constraints of the current environment that we're operating in. So we're making progress. Progress is hard, but it's really worthwhile once you see the outcomes coming from that.
So do you think there needs to be more work around this with the government, with some insurers involved and other organisations actually bringing that all together, and then it actually showing some tangible results?
We're doing work with both, right? We're doing work with government, we're doing work with NIB up north, and so... But ultimately, it's actually up to the providers to choose to do something different themselves. Like, we've invested heavily into primary care. I think we're the only organisation in this country that can say that we've invested 45 million into primary care over the course of the last 3 years or so. So we have invested heavily into primary care to try to improve the current operating paradigm. And so yes, government forms a part of that. Yes, insurance forms a part of that. But more broadly, we actually need the big players, and in particular the corporates, to take more accountability here and actually make sure that their practices are operating in a way that's actually best going to benefit their patients.
Sure. Alex, you said that South Korea has been tackling this, and there's a lot of learnings there as well. What are some of the similarities and the learnings that you see between New Zealand and South Korea, and how you see that working here in the future?
Yeah, I mean, I think they are a little bit further along the journey, along the sort of solutions that Cecilia is speaking about. So we see some pretty innovative healthcare solutions, digitization, etc., democratization of information, really more end-to-end service integration as well. So I think those are some of the key challenges that I think Cecilia's hit the nail on the head. It is quite an eye-opener as an actuary and a person who likes to use data, the data and the technology that I see within our current sort of end-to-end infrastructure and how it does not speak to each other is
I mean, like,
quite
Starship
observable.
Operates off Post-it notes, basically, and paper. Like, it's a whole system. All of it is broken.
And it's just difficult to identify inefficiencies and really improve the whole system if you can't join all those dots.
Kate, would you like to add some more to that?
Just probably that consumer demand is going to shift this paradigm, I think. I mean, it's interesting working in public and private, how much more quickly private can move when there's a consumer imperative to do so. And I think what we're going to start to see is consumers will walk with their feet. And we're already seeing that, like disruptive new incumbents like Tend and others, they're disrupting the market. And it's fantastic to see, because it's making everybody else who's been a bit asleep at the wheel go, crikey, if I don't move, I'm going to be out of business. And in the private market, that's very evident. In public, it's a harder beast to shift. It's a bit like shifting the Titanic. I mean, there's a lot of investment needed. We have, 12,000 reasonably ancient servers, 6,000 plus clinical applications, many of which, were purchased to run a whole department, still sit on a computer under somebody's desk in a so those sorts of things, they've got to change, and they've got to change fast. And we've got a fantastic team of data and digital people at Health trying desperately to do that. There's a whole bunch of cleaning that up and getting baseline right before you can transform. The hard thing is we've got these transformative new innovations in market, but they're in pockets, so they exist in parts of New Zealand. they can't scale, we can't roll them out at pace, and we can't do it cheaply enough because the infrastructure backbone is so old and needs replacing. The challenge when you've got a public health system that's got no money and is doing a sort of cost turnaround project at the moment, that's a real challenge. So I think private is...
Well, this is the thing as well. I mean, I'm saying we've spent 45 million to achieve what we have, but if this would have been done by government, I'm guessing 1 to 2 billion, possibly more. And that's not just making numbers up. That is what it would cost to develop what we have developed inside our organisation, right? So it is a benefit of being in a private environment where you can make fast decisions. And I think from my perspective, there's a whole heap of write-offs that needs to happen in our healthcare system. We just have to swallow that we've made some wrong decisions, and we actually have to just move forward, right? Because technology has vastly improved from the systems that were implemented 10, 15, 20, 30 years ago, right?
And Alex, from your point of view, with health insurance in particular, how will that evolve to be more supportive as that, people are getting older, it's getting a lot more expensive, and we really want them to retain that. So there is that pressure off the public system there as well, right?
Yeah, I mean, I think I sort of touched on it in the start, is we can't just be a payer of claims. We can't just be pushing up premiums as incidence keeps creeping up. We need to partner with our members, with society, and look to see how we can improve healthy outcomes and raise health awareness for all of society. I mean, I think it's the only solution.
I think it's cool in the US, Kaiser Permanente are able to evidence that in 20% of their population they've been able to reduce the presentation of bowel cancer. And because they see their hospitals as a cost centre, that's the way that they think. They want to lower costs. They don't want them in the cost centre. So, they actually think in a way that makes really good sense from a system perspective. And we don't think like that in here. One of my biggest bugbears there is Pharmac. Like, this drives me crazy. I was in a conversation, it was actually with Stephen Joyce the other day, and I was just lamenting the fact that the cost-benefit analysis of funding medication versus keeping people sick within our system, we're not thinking like that. We're not thinking about the cost that it's costing our hospitals to pay for people to receive complex, expensive diabetes care, and the cost to their family and their children and their work and them as taxpayers. We're not thinking about what the cost actually is, and instead we're just not funding medication appropriately. So there's much broader issues here at play, and all of them need to be considered if we truly want our population to be healthier.
There's a question from the audience. It says, there's plenty of consumer demand and ongoing high expectations for healthcare. Do we need a reality check on the healthcare system we can afford? If the government sticks to its operating allowances, as Nicola Willis said this morning, where will the capital for better healthcare come from?
Well, I'm a little bit frustrated because while we've got, and I just want to be careful about how I say this, we're absolutely underfunded as a sector, but so is every other sector. Education, early childhood, like you look around and there's not enough money to go around. So we actually, as providers, need to take more accountability to do better with the funding that we receive. And we need to find more innovative ways of lowering costs to our patient base. And, the fundamental part of that is that doctors are really expensive to hire. They're really expensive to train. And so one of the biggest things that you can do is ensure that the doctor doesn't have to see everyone, that we have to triage appropriately to the right person at the start, rather than have the GP or the doctor be the gatekeeper to other service providers, right? And so that's one of the things that we're doing at TEND, is triaging for our app to enable other healthcare professionals to provide first-line care, rather than the GP being the person that has to hold all of the relationships. And so we have to be more smart, and then we have to increase productivity. At TEND, we've developed an AI tool called Scribe. We're able to evidence that if you're not using Scribe, 40% of your appointments finish on time. If you are using Scribe, 90% plus are finishing on time. And so, there are things that we can do to improve that productivity and better spend all of our taxpayer money, because while we've got, our sector out there crusading, which, for more funding, if we go from a 4% uplift in capitation funding to 140% uplift in capitation funding, I'm really intrigued to see where that money's going to come from. So while I'm in favour of ensuring that we're appropriately funding our system, we as providers also need to spend our money that we're being funded well and appropriately.
Yeah, I mean, I'll just quickly touch on before I pass on to Kate. I mean, we have to tackle the situation systemically, the whole system. So certainly, if I speak to our chief medical officer sitting at a group, ex-CEO of a hospital group, he says, hand on heart, at least 25% of expenditure is wastage. So unless we're able to identify that and optimize those patient pathways, you're fighting a losing battle.
I think one of the phrases that we use for this technology enablement, I guess, is a force multiplier. It's been really interesting watching the workforce and the nervousness they have, or the lack of trust they have in the adoption of some of these new technologies. I'll give you an example. We rolled out an AI Amazon ServiceNow tool to aged care and in Canterbury, and effectively it was a replacement to the call bell. That is the most really, if you think about it, the most dumb technology ever invented. It's a bell, and it pings a bell in front of the door. It doesn't triage the staff member that's required. It gives the staff no indication of how severe that person is sitting there in pain or has fallen out of bed. So we created a voice-activated replacement just using off-the-shelf Alexa, and it was incredible how the patients loved it, their families loved it for a whole bunch of other reasons. The nurses were using it to play, classical music to calm patients down so that they could turn them and bathe them and do all sorts of other use cases. But the biggest feedback was from the nursing staff that they felt they were being policed, because actually what it did is it reduced the amount of falls by about 25%. That's massive in a hospital system when you think about the cost of a fall. And that reduction alone would have many times overpaid for this solution. But the staff resisted it on the basis that they were concerned it was like a big brother. It was measuring how quickly they responded to a call bell, because now all of this was digitized, the data was there, the information was there. Interestingly, in doing that project, we realized that the call bell data service had been turned off for 6 years, and they actually had no data in terms of how. So, this is the power of technology to enable care, to reduce waste, to take some of the high cost out of the system that can be redeployed. I do think there's a tipping point, and the piece is, how do you get to that point where you have enough innovation in the sector to show people that this is working? And I do think that probably will come through public-private partnership, and certainly this government are very behind that, which is good to see.
Cecilia, did you have something to add to that?
I was just going to say that's such a good example, and we probably have 100 of them in primary care. It just is prolific. It's prolific, and you're implementing tools to make your clinicians more productive, to be able to enable them to see more patients, for the patients to be able to have better experiences, and the level of sector-wide resistance to change is significant. And the answer to it is not just pay people more to do exactly what they're currently doing. That is not an answer. It is actually to pay more to ensure that we get the outcomes that we're looking for as a society, and ensure that we have the transparency and the governance in place to actually ensure that we're delivering on the things that we say that we're going to do. And so as a taxpayer, it actually makes me quite mad when I see it and when I hear about it, and that's how I think about it.
Do you think that the retirement pension age will need to increase in the future to be able to support an aging population? And do you think New Zealand as a society will have the health span for this to happen?
I think personally I would want the retirement age to increase. I think there's some evidence that indicates that the more we're able to stay an active and contributing member of society, the better our healthy outcomes. So, and certainly if looking at yesterday's session in this room, I think there was an indication of 60 years to pay off your mortgage. So certainly you're going to be needing to work a hell of a lot longer to pay that off. But yeah, certainly I think worldwide we've started to see it creeping up in certain countries where there is a mandated retirement age. I think there's a will from a lot of people that would like to continue working and contributing to the workforce. So I think it would be good to see at least a better societal normalizing of allowing people to work longer.
And do you think the Healthspan will actually catch up, or at least get a bit closer?
I mean, I think there's work to be done. I think the FSC stats showed that New Zealanders and Kiwis in general are healthier longer, or at least perceive themselves to be healthier for longer ages. But I mean, as we see in a lot of developed economies where people start to live more sedentary lifestyles, some of these diabetics, etc., start to creep in. So that awareness does need to be created.
I think more broadly, though, when we talk about life expectancy and lifespans, I think it's important to acknowledge that Māori lifespan is not as long as Pākehā lifespan in this country, and by 2040, I think 1 in 3 children are going to be born Māori. And so unless we resolve some of the health inequities that we have that are systematically prolific throughout our system, then that actually won't happen. We won't actually see a longer lifespan. So, I mean, it's just, we have to actually ensure that those who are most at risk, those who are most vulnerable, are actually able to catch up as well. And that's something that's really important. And, you know, that focus, and it's a big focus for us inside Tend Health Equity, is massive. You know, we see our biggest uptake, unsurprisingly, Māori, Pacifica, Asian. In fact, it's actually really funny at Tend, because one of the things that we see is our customer satisfaction is highest for Māori, Pacifica, Asian, Pākehā last. Why? Because they're not being well served by the rest of the system, and so they're grateful to actually have an engagement with a primary care provider who actually cares for them in a different way than what they used to. So we have to bridge that gap. It has to be a priority. It has to be something that's talked about, because it's an unhelpful narrative to talk about the fact that our life expectancy is increasing, but for a certain demographic it's not. And that needs to be acknowledged.
And Cecilia, at Tend, how are you driving that experience in Maori Pacifica?
Well, and when we started, everyone said, you're going to increase the health equity gap because these people don't have access to phones and data and the internet, and it's just bullshit, to be completely frank. In fact, our highest uptake is in Māori and Pacifica. Again, in our Pakuranga practice, we went from 8% Māori enrolled pre-Tend to 18% post-Tend, 2% Pacifica to 14% Pacifica, a 7-time increase rate in the level of enrolment. And that is because if we're engaging with the community, it's easier to access, they can use their phones. You know, and I think a lot of us who come from a privileged background where you don't have to take time off work to go and take your kid to the dentist or the doctor, where, you know, you can easily fit into this, you know, 2 o'clock dentist or doctor's appointment, you know, it's a very different lifestyle from those who can't. And so if you can enable them for having longer opening hours, for enabling them to access care on the weekend, then that will improve healthcare outcomes. And that's what we're seeing.
I did read an article in the Herald, I think, maybe this week, where some people were waiting close to 5 hours and lining up in the cold to actually go to
That article
GP.
makes me really mad, because the model is the choice of the provider.
Yes.
The fact that these people are waiting outside in the cold, let's be clear on that. That is Tamaki Health that is making that happen through their private equity firm, Mercury Capital, which is Australian owned. So that article for me, you know, didn't sit well with me, because that is their operating model that is dictating that those people are standing outside in the cold in the morning. That is because they wait using a wait list to manage they're using a queue-based system to manage how their patients access care. And that is not equitable. And so for me, we want to be really careful about how we tell the narrative and the role that providers also play as part of that narrative.
Correct. So, Alex, you mentioned, you know, all those vitality stats about where you're seeing the blood pressure management, the diabetes care management. Now, how do we balance all of that, all the good stuff that Vitality is doing, with the cost of emerging new technology and more expensive procedures, such as robotic surgery, cost of more expensive drugs? How is that going to be balanced in the future?
Yeah, I mean, I think overall, if you're reducing incidence, then you're creating a natural balance. But certainly there is a challenge with increased robotic or other types of innovative treatment. But I think the cost of those does tend to come down over time as well. And I think a lot of that stuff is scalable. So I think we've already, the Tend example is a good one. For example, my sister currently does radiology in New Zealand, but she lives in South Africa. She does it via teleradiology. We've seen the latency on robotic surgeries reduced, so it become more of a practical possible solution. So I think there will be a bit of a lag effect, certainly, but as those become more normalized and efficiencies start being realized, then hopefully that starts feeding through, and then reduces the supply side constraints that we currently experience within the healthcare system.
And I guess on that note, like when you have morbidities like BMI, NIB is working with its own members trying to offer proactive management there through our health management programs. AIA has Vitality, and hopefully we can see more of that scope in the public-private healthcare and encouraging more management along those ways, right?
I think a lot of this is here already. We just haven't, again, scaled it to the masses or made it mainstream. So, I mean, I was listening to Cecilia talk the other day at an Innovators Summit, and we were talking about cervical screening. So we know currently there's a modern new cervical screening test that is available in New Zealand, but in order for women to get that test, they have to rock up to their doctor, pay to see a doctor, to be handed the test, to go into a room, to do the test yourself, which you could do at home, and then to pay for the privilege to block a space potentially that could be being used by somebody that needed it more than that individual that's well and healthy. So that's the kind of opportunity that I think in New Zealand exists today. We've just got to turn that on, and we need consumer demand. So, you know, I'm a female, I've got two beautiful young girls that do not want to go to the doctor and pay $60 for the privilege of something they could do at home in their own bathroom with a click on their mobile phone to say, my personal health record, send me a test and I'll do it myself. So, you know, the crazy thing is that technology exists. It's just the system's operating model has not fallen in place as fast as some of these technologies are arriving.
This is choice. I just want to be really clear on this. When they mandated this, I think last year, the initial way that they were going to enable us to deliver these services to the community was for people to be able to home screen, because apparently during COVID we proved that we were adults and we knew how to test ourselves, but suddenly we'd lost that privilege and we don't know how to test ourselves. And so that in itself is an incredible frustration, and it is the role of innovative providers to push those boundaries. We're not quite pushing them yet. I'm trying to actually be collaborative, although I'm struggling with that, and actually talking to the right people to change things. But we will push the boundaries on things where we think it makes sense for our population, ultimately.
And do you think screening in New Zealand is adequate? We offer it at quite older sort of age thresholds. Do you think there is a more inclusive way of including screening as part of daily healthcare?
Yes, is a short answer. I think for us, again, like the biggest problem in the healthcare system is that you've got this constant need for urgent care, and it's constant, and it's there all the time. People have got coughs and colds and broken bones and rashes and weird stuff going on with their bodies. Great, right? But what happens is that the system caters to the urgent care need and forgets about the fact that where we actually need to do the work is the preventative and the proactive side of healthcare. And that's actually where we'll get the most return as a country, as a community, for our families, as taxpayers, all of the above, right? And so there's absolutely ways that we can improve that screening, and that's for protecting time to ensure that the right people are being seen in the right way at the right time. And so for TEND, for example, again, not rocket science, with our app, we're developing a timeline which will be deployed for all of our patients in the next period. I'd love to have my COO in here so I can say exactly the date, but it's meant to be in the next 3 to 6 months, and literally there will just be a persistent flag that sits on your account that just tells you that you haven't done your cervical screen, or you haven't done your prostate check, or you haven't done your mammogram. So think about it, if you went onto Instagram, and Instagram every time, or Facebook, or the New Zealand Herald app, or whatever you use, tells you haven't paid, or you know you haven't done this one thing, you need to update your card, whatever it is, you ultimately do it because it's painful. And so it's not that hard to create consumer pathways to enable them to be screened. It's just about how we're executing it in a world where actually technology is an enabler and not something that is, 20 years old.
I think possibly consumers are the most underrated, overlooked talent in our workforce, in our healthcare workforce actually. But to your point, they need the tools to be able to do the job themselves. Many would like to, but we haven't enabled that. We have a very paternal, quite didactic health system that is done to rather than for or with or enabled by consumers and consumer directed rather than, care directed. So I do think that's a massive opportunity.
Yeah, I think there's so many new and innovative ways to screen these days that we need to just stop holding ourselves back. I think us as insurers also have a role to play in opening up access faster, as does government and the rest of the infrastructure.
Alex, on that note, so how do you see an insurer playing more of a role there, and what will they be making sort of available?
Certainly looking out into what's available and then incorporating that into whatever infrastructure you do have or processes. Obviously, I've already talked to Vitality and how I've seen that far more advanced in other countries. There's certain markets where we've got facial recognition software in play that can give early signs of certain ailments, etc. So that sort of thing. It is a fine line. You don't want to be alarming people unnecessarily. You don't want to be misusing the information, etc. But certainly there's more we could be doing to flag things earlier, open up innovative procedures, scale things, get things to the consumer a little bit quicker.
Yeah, two examples kind of on two different ends of the spectrum. So in Northland, we don't have any access to primary care services. Books are closed. If you're in Northland and you just want to get a regular, in particular in Kaitaia, you want to get cervical screening done, you want your child to be immunised, you want, your prostate checked, you can't get screened for the basics because practices are not enrolling patients, and you watch the news, you kind of go, oh, I'm so lucky I sit in Auckland and I've got a local doctors, but actually it impacts all of us. Emergency rooms being full, the next time you're up there and you're holidaying or whatever it is, you're impacted by the fact that you can't access the emergency room because it's actually full of all these poor people who haven't had their regular screening. So we need to think broader than the fact that it's, we actually impacts all of us, and we have to get our entire population screened, which is the same as the life expectancy span. But last year my husband and I were in the US and we did the Pronuvo scanning, which is $5,000 a person, and it's an expensive exercise to do to tell you about your body. But it told us that we both had a low-lying Kühnast on our spines. And interestingly, when our third son was born, through another issue that he had, it was picked up by Starship that he had what they perceived to be quite a big issue. And so we went through Starship. He had ultrasounds, he had MRIs, he had, we saw the head of neurology, we consulted with all these people, right? Cost the system a lot of money, only to find that biologically, because both his parents have this, he actually has the same thing as we do, and we're both functioning, we can both walk. And so if we would have known this about ourselves, if we would have had that information early on, we wouldn't have taken up all that time in the system assessing him. And so there's two sides of the spectrum. Yes, there are all these amazing advancements that can tell us more about ourselves, where, the future of healthcare is really positive, but also we need to do the basics. We need to be screening, immunising some of our most at-risk communities, because if we're not, we're going to have a return of illnesses that we're not currently prepared for. And, I think measles is a really good example of that.
Yes, that's a really good point. The FSC research also stated that whilst, like you said, lifespan has increased, a lot of the people are spending the last 3 to 5 years of their life in poor health and really needing the health system more than they probably would have used in their entire life. How do we see that being balanced when, like you said, our emergency rooms are already packed to the brim? Most of the times we can't even get appointments in. How will that population then start to be able to access it more regularly if they need?
Well, practically what's happening, and what I believe will happen, is that they'll introduce, and this is just a detail of the funding system and that will bore most people but entertain me, but the problem is that currently right now, if you're over 65, your capitation rate that you get funded and that a provider gets funded to take care of you is the same as if you're 85. Now let's acknowledge that a 65-year-old is very different from an 85-year-old, so we actually need to create another capitation funding streamline for people that are of a certain age, maybe over 80, maybe 75, I'm not sure what the age is, to incentivise providers to actually ensure that they are keeping them healthier in their communities, because the answer is not hospital-based care. We need to be able to try to keep people in their community healthier for longer, and it's going to cost more money in the short term again, but that's a return on, you have to look at the cost benefit analysis of that, because if we're instead having to put them into hospital-based care, that's going to cost us a lot more. So you kind of have to prepare for that at the start by funding the system appropriately to be able to deliver the services.
And how do we see technology playing a part in that?
Same. I mean, enabled using technologies like TEND or large-scale solutions that are able to meet the needs of the communities, both in the home and in primary care, but it all has to be linked together. And again, this is where you get back to the fact that we don't have a digital health record across all of New Zealand. I mean, we do for TEND, but we are the only provider across this country that has a single digital health record across all of our practices. So if you're with any other provider, effectively, they only have a single instance of the record at that practice. And that's part of the problem in the sector.
There are some easier things to do too. We know that socially isolated older people are 50% more likely to end up in ED. That is a really easy problem to solve through technology and connecting people with other people like them. And that doesn't need to be the health system that does that. That could be aged care, that could be community groups, NGOs, private providers, all sorts of church groups. Iwi, Pacific providers are doing a lot of that work already with, social engagement and community neighbourhoods. And I think we saw a lot of that in COVID, that whole care in the community, looking out for your neighbour. And I do agree, I think we've gone backwards, and that worked really well. We did some work with the whānau here in Auckland, where the point of entry to these vulnerable homes was often through a food bag, and the offering of food to a family that needed it then opened the door for a conversation about a whole bunch of health concerns that family had. Not one appointment to discuss one disease or one issue, but actually several meetings over several weeks to discuss a whole range of preventative interventions that potentially can, have kept many of those families out of needing to use health services, particularly in, secondary care and hospital-based. So I think, that's the piece that needs more funding and more attention. And I'm hopeful that this new operating model and the new sort of funding primary care, community services is going to actually get the levers right, because people know that that's the right, we all know that this is inherently the right thing to do. Prevention makes more sense than treatment. But actually we've got to get the funding levers right so that it's easier to do the right thing.
Alex, would you want to maybe add to that from an insurance point?
Not necessarily from an insurance point, but certainly some examples. You asked about South Korea earlier on. We have seen technology like people like you, matching people like you, and certainly in certain health conditions that's also been proven to provide an additional support base and with better outcomes. So certainly connecting certain people that are suffering from certain similar ailments, or just providing that additional network.
I think we are nearly at the end of our session. We'll just go around and if you would just maybe add your thoughts and finish the session off.
I guess I'd just probably go back to, we have a really exhausted healthcare workforce right now that are doing, such an incredible job under very trying circumstances. And I do think that we need to shift it almost needs a campaign or a movement. There's something that's come out of Ireland that's taking global attention called Shift Left, Stay Left 10 times. And I love that because it kind of gives a brand to what we're trying to do, which is effectively in order to shift care to the left and then keep it to the left, e.g. in community and homes, primary care, you're going to need technology-enabled businesses and technology-enabled workforce that are 10 times more effective than one person on their own or one solution on their own. And those are the things that we should be doubling down on, investing hard in. And then, in some ways back to that force multiplier, for every person in our workforce that's providing care, they almost have like an army of 10 digital technology tools in their pocket that can help them be 10 times more effective. So I think that's got to be a focus for New Zealand, and we need to jump on that movement fast.
Yeah, I don't think there's a lot I would add to that, I think we just need to structurally remove the blockages. I mean, we're encouraging inefficiencies, and I think as soon as we start actively campaigning to remove those, we'll see the benefits and upticks. I was wondering if this conversation on wearables would delve into the swallowables, which was something that came up into the sort of gambit of thinking many years ago when wearables was first introduced. So the idea of swallowing certain devices, and so that you can be tracked infinitum and get a little ping when your blood pressure starts raising, etc. But thankfully we didn't go there. I think there would be some concerns around that. But I think the preventative screening and the use of technology and really getting information faster to the right places, that's where we need to be headed.
Yes, I think for me, well, I'm kind of like bogged down in the challenges of day-to-day primary care, which drives me mostly batshit crazy. And I was having an argument about a dictaphone before I went in here. Ultimately for me, what we're working on is to help New Zealanders be the healthiest people in the world. And sometimes I'm in big groups of people and it's like 300 people in the room, and you say that and you get some people eye rolling at you, and it is really achievable. There is 5 million of us, and that is our purpose. And I feel really strongly that we are able to. I can see the progress that we're making. It is not that hard. Yes, it is costly, but it's not that costly. And so I've got a really high conviction that in 20 years' time, we're going to be a country that people are going to come to see the things that we have done to our healthcare system that will truly be world leading, right? And that's not where we are today, but that is our vision for the future.
Great. Thank you so much, panelists. I mean, what we can take away from this session is that the greatest advantage of technology is being able to have the freedom of choice in terms of how you access healthcare, primary care, but also knowing that everybody wants to access it their way and access it as efficiently as possible. And hopefully we get there in the future. Thank you.